This is Dr. Ankur Shah, and this will be a talk on giant cell arteritis. In this talk, we will give a brief overview of giant cell arteritis, also known as GCA or temporal arteritis. In particular, we will cover some of the clinical features of GCA and touch on some of what's known about the pathophysiology of this disorder. Finally, we will talk about therapeutics that are out there and how we use them to help our patients. Here is the basic outline of this talk. We'll start with a patient presentation and then go through the various topics listed here. Let's start with the case. A 72-year-old female presents to your primary care office complaining of a throbbing, continuous headache over her temples, as well as tenderness of her scalp and pain in her jaw on the right when she chews. These symptoms have been going on now for about 4 weeks. In addition to these symptoms, she has had muscle aches in her shoulders, neck, and upper thighs for the past month or so. On further questioning, she notes a 6-pound weight loss over the past 3 months. Based on these symptoms, you consider a diagnosis of giant cell arteritis. GCA is almost exclusively found in patients over 50 years old, and the average age of diagnosis is around 70. The prevalence of this disease is approximately 200 per 100,000 persons over 50 years old. An increased prevalence has been observed in those of Northern European heritage in the US and Europe. The incidence, or the number of new cases per year, varies by location. In Europe, there are about 15 to 25 new cases per 100,000 people in Northern Europe, and a much lower 6 per 100,000 in Southern Europe. As observed, with many autoimmune diseases, women are affected 2 to 3 times more often than men. How is GCA defined? It is considered a vasculitis or inflammation of the blood vessels. More specifically, since we tend to group vasculitides together based on the size of vessels typically affected, GCA is considered a large vessel vasculitis. GCA typically involves the extracranial branches of the aorta, sparing the intracranial vessels. It can also involve the larger mesenteric branches of the descending and abdominal aorta. GCA can be associated with polymyalgia rheumatica, otherwise known as PMR. PMR is 2 to 4 times more common than GCA. Not all patients with GCA will develop symptoms of PMR, which include pain in the neck, shoulder girdle, and pelvic girdle. Only about 15 to 30% of patients with PMR will develop GCA, but it is important to look for GCA in these patients as it can clearly affect prognosis and treatment. PMR is the topic of another Learning in 10 lecture. The pathophysiology of GCA is somewhat complex and likely involves an interplay between environmental and genetic factors. In association with the human leukocyte antigen, or HLA gene, HLA-DR4 has been observed. HLA-DR4 may then genetically predispose some individuals to developing GCA. At the cellular level, systemic macrophage and T-cell activation with cytokine production plays a role. The production of cytokines, in particular tumor necrosis factor alpha and interleukin-6, appears to closely correlate with the severity and expression of systemic symptoms. Here we show the main arteries involved in giant cell arteritis, in particular the superficial temporal artery. If we were to take a cross-section of this artery, what would we see? Compared to the normal artery, we first see initial damage to the media and internal elastic layer. Second, panarteritis develops and intimal proliferation causes luminal occlusion. Granulomatous infiltration of monocytes, CD4 T cells, and macrophages develop. In addition, giant cells, where the name giant cell arteritis comes from, are clustered near the disrupted internal elastic lamina. All of these features can lead to significant dysfunction, inflammation, and occlusion of the vessels. This is a pathologic specimen from a temporal artery biopsy in a patient with giant cell arteritis. Histologically, the tunica media thickens and the lumen narrows due to tunica interna fibrosis. Giant cells can be seen populating areas around the internal elastic membrane. Clinical findings are the key to making the diagnosis of GCA. The vast majority of patients present with a headache, which is often in the temporal region and can include tenderness of the scalp. Headache, however, can be nonspecific. Pain with chewing or jaw claudication, which is tiredness of the jaw with chewing, as well as diplopia, or double vision, tend to be the most predictive features from the patient history. About half of affected individuals present with symptoms of polymyalgia rheumatica, as noted on previous slides. Many patients will also have fatigue and malaise. Some patients present with systemic symptoms such as fever. About 10% of patients present with more concerning symptoms, such as amaurosis fugax or transient loss of vision in one eye, implying inflammation of the ophthalmic artery. A small minority of patients experience symptoms consistent with a stroke or transient ischemic attack. Physical examination may also provide clues to diagnosis. Special attention should be focused on a few specific areas. Palpation of the region of the superficial temporal artery on the scalp can demonstrate tenderness, redness, and/or thickening. Retinal exam is critical to evaluate for anterior ischemic optic neuropathy. This appears as a pale disc with blurred margins as seen in this picture. AION is the most common cause of visual loss in these patients, which is one of the most severe consequences. Finally, involvement of the carotid may lead to an audible bruit on auscultation. In addition to the clinical findings, other diagnostic tests may be useful in confirming the diagnosis of GCA. Most patients will have an elevated ESR, usually over 50 millimeters per hour, but may be higher than 100. C-reactive protein, another marker of general inflammation, is also usually elevated. In fact, up to 100% of patients may have a normal ESR, and CRP may be a more sensitive test. Other tests for rheumatologic conditions such as ANA and rheumatoid factor are normal. Imaging studies are beginning to be utilized to aid in diagnosis, although not routinely used in practice. The gold standard for diagnosis, however, remains biopsy of the temporal artery. Some studies report that biopsy has over a 90% sensitivity and specificity for diagnosis. Some centers perform bilateral temporal artery biopsies to improve the yield, as it is a fairly low morbidity procedure. It is important to note that if there is a high enough suspicion for GCA, treatment should not be delayed while waiting for the performing of the biopsy or awaiting results given the concern for possible irreversible vascular complications. The mainstay of treatment is glucocorticoids or steroids like prednisone. As mentioned, treatment should start immediately when the clinical findings suggest a diagnosis, particularly if there is evidence of eye involvement. Starting prednisone even several days before a temporal artery biopsy will not affect the diagnostic yield. In fact, significant response to steroids within 24 to 72 hours is very suggestive of the diagnosis. We generally start with 40 milligrams to 60 milligrams of prednisone per day, depending on the severity, and taper down slowly over the course of 6 to 9 months, generally tapering the dose by 10% at a time. Once 5 milligrams daily prednisone is reached, the taper generally slows to 1 milligram, decreased each month as tolerated. With a long course of corticosteroids, one must be alert for side effects such as elevated blood sugar and address prevention of bone density loss, particularly in the elderly population. Most patients do well with appropriate diagnosis and treatment. However, visual loss is uncommon but an important consequence. Only a minority of patients, less than 10%, have significant visual improvement following vision loss due to AION. Other vascular complications such as aortic aneurysm or other large artery stenosis are other possible consequences. So, in summary, giant cell or temporal arteritis is a large vessel vasculitis affecting patients 50 years or older. It typically involves branches of the aorta, especially branches of the external carotid artery where there is significant infiltration with inflammatory cells and mediators, including collections of macrophages called giant cells. Diagnosis is based on clinical features, elevated inflammatory markers, and the results of temporal artery biopsy, which is the gold standard for diagnosis. Normal inflammatory markers makes GCA much less likely, and alternative diagnoses should be considered. Prompt diagnosis and treatment with glucocorticoids, even before biopsy results return, is critical to prevent potentially permanent visual loss. And here are some key references for you to read and learn more about giant cell arteritis and large vessel vasculitis.